All right, let's just dive right into this explainer where we're taking that massive clinical guide on Candida and turning it into your ultimate exam trap survival guide for the medical boards. If you're preparing for these high-stakes medical exams, you probably already know the basics of fungal infections. So today, we aren't just reading off facts. We are actually decoding the minds of the test writers to spotlight exactly where they want you to trip up. Since medical training is literally all about structure, here's our high-yield roadmap to perfectly categorize these clinical pearls and save you some vital study time. We're going to hit species and resistance, clinical presentations, disseminated red flags, treatment principles, and finally, the ultimate exam traps. Let's get to it. Okay, Section 1, Species and Resistance. Know your enemy. Let's see how this builds our foundation. So when we break down Candida species, look, Candida albicans is your standard fluconazole-sensitive baseline, right? But honestly, test writers, they do not care about the baseline. They care about the exceptions. You absolutely have to link C. cruci with intrinsic fluconazole resistance, like hardwire that into your brain right now. If a question stem mentions a patient growing C. cruci, asks for the next best therapy, and you pick fluconazole, man, you've just fallen right into their trap. For cruci, and actually for C. glabrata too, since it has reduced sensitivity, an echinocandin is definitely your preferred move.
Now I want to introduce you to the new big boss of exam questions, Candida auris. This isn't just some interesting bug, it's literally classified as an urgent CDC threat. And why does this matter for your boards? Well, standard labs often totally misidentify it. So if a vignette casually mentions a yeast-only isolate from a hospital outbreak, and they had to use MALDI-TOF for identification, and oh, it grows at 42 degrees Celsius, they are essentially screaming Candida auris at you. And the scale of this threat is honestly terrifying. We are talking about a staggering 93% resistance to fluconazole. Think about that. Plus, about 35% are resistant to amphotericin B, and some are even resistant to all three major antifungal classes. Crazy, right? Because of this massive azole resistance, echinocandins are your strict, non-negotiable first-line therapy here. Please do not mess around with azoles for C. auris. Moving on to Section 2, Clinical Presentations. The clinical battlefield. Okay, picture this on test day. A healthy 25-year-old comes in with painless white oral patches. What is the next step? Now, I want you to just pause for a second here. Rely on those clinical reflexes before you jump straight to writing an antifungal prescription. We all know painless white oral patches showing pseudohyphae on a gram stain equals oral thrush. But come on, thrush doesn't just spontaneously happen to a perfectly healthy 25-year-old out of nowhere, right? So the answer to that last question, you need to investigate for HIV, because HIV is a major, and I mean major, risk factor for oral thrush in a young, otherwise healthy adult. But here's the trap. HIV is explicitly not a major risk factor for vulvovaginal candidiasis. If a patient comes in with recurrent vulvovaginal infections, the test writers actually want you looking for recent antibiotic use, especially beta-lactams, or maybe pregnancy or diabetes. Do not mix up the risk profiles of these two mucosal compartments. It's a classic pitfall. Let's pivot to genetics real quick, because board exams absolutely love their rare genetic zebras. You might know chronic mucocutaneous candidiasis, or CMC, is linked to IL-17 pathway defects. But the ultimate high-yield zebra here is APED syndrome. You need to immediately, like a reflex, associate APEDs with a mutation in the IRE gene. If you see a patient with persistent skin and mucosal candidiasis who just so happens to also have hypoparathyroidism and adrenal insufficiency, boom, that's APEDS. Along those same lines, what if a completely healthy individual suddenly develops Candida meningoencephalitis? You're going to want to test for CARD9 deficiency. This one is super testable because it is literally the only primary immunodeficiency that has a fungus-specific susceptibility. It's this very specific, isolated defect that leaves the patient totally wide open to central nervous system candidiasis. Okay, watch out, because here is a massive trap. It is so incredibly tempting to think, oh, this patient has chronic mucous cutaneous candidiasis. They must be at risk for a devastating bloodstream infection. But no, actually scratch that. They almost never get it. Why? Because patients with CMC have perfectly intact neutrophils, meaning they rarely develop homogeneously disseminated disease. Their defect is purely in the mucosal defense via the IL-17 pathway, not systemic clearance. So keep their disease localized in your mind. All right, Section 3, disseminated red flags. Massive flashing neon lights
So, if a question stem casually mentions, oh, papules or nodules with a necrotic center, those are macronodular skin lesions. Or maybe the patient is having eye complaints at chorioretinitis during candidemia. You guys, the examiner is screaming at you that the fungus has disseminated to multiple organs. These aren't just random physical exam findings to brush past. They are the exact diagnostic clues confirming hematogenous spread.
And that brings us to an absolute non-negotiable rule. I literally cannot emphasize this enough. An ophthalmologic exam is absolutely mandatory for all patients with candidemia. Up to 20% of these patients develop ocular lesions, and if you find one, it means there's a 90% probability of deep organ abscesses elsewhere. It completely changes your management game plan, dramatically prolonging treatment well beyond that standard 2 weeks after the last positive blood culture. Which leads us to Section 4, Treatment Principles. The arsenal. Let's talk about fighting back. Burn these 3 sequential steps into your memory for candidemia management. Step 1, start an echinocandin, like caspofungin or micafungin. Notice the modern shift here. Echinocandins are your first-line therapy for candidemia now, not fluconazole, especially before you know the exact species. Step 2, remove or replace the central venous catheter. Fungi absolutely love to form biofilms on those lines. And Step 3, order that mandatory eye exam we just talked about.
But hey, watch out for the endophthalmitis trap. We literally just said echinocandins are your go-to for the bloodstream, right? Well, despite being the champions of the blood, they have terrible, just really poor ocular penetration. So if that fungus gets into the eye, you absolutely must switch your arsenal to amphotericin B and flucytosine. Oh, and for candida endocarditis, medical management alone almost always fails there. You've got to surgically remove the infected valve and put the patient on chronic, sometimes indefinite suppressive fluconazole.
All right, Section 5, Ultimate Exam Traps, the final summary.
Let's dive into our climax here, a rapid-fire, highly screenshotable rundown of the absolute most critical exam traps. Get your mental cameras ready. First, lock in your risk factors and genetic zebras. If you misattribute HIV to a vaginal infection or assume a completely healthy person just gets thrush without some underlying immunosuppression, you're going to lose easy points. Remember the counterintuitive nature of CMC. Intact neutrophils mean no systemic dissemination. And forever link apacide with the IIRE gene and those endocrine issues. Second, memorize your absolute rules for management. The eye exam is mandatory, no exceptions. C. crusea is intrinsically resistant to fluconazole, period. Echinocandins are your first-line defenders for candidemia, but remember their Achilles heel, that poor ocular penetration. And finally, never ever leave a central line in place when a patient is bacteremic or fungemic with candida. Pull that CVC immediately. As we wrap up this explainer, I want to leave you with a challenge. Take a look at this question. When you see a patient with new-onset candidemia in a vignette, what 3 absolute must-do steps should instantly pop into your clinical mind? Ask yourself, are those 3 steps, start an echinocandin, pull the line, check the eyes, are they second nature yet? Because if you can master this sequence and anticipate these traps, you are going to completely dominate this topic on test day. Keep studying smart, stay focused, and hey, it makes you wonder, what other infectious disease traps are hiding in plain sight? We'll dive into that in the next explainer. See you then.